good morning. I'm Al McFarlane. Welcome to Conversations with Al McFarlane. Today's broadcast coming to you from the beautiful location of the heartbeat, the public policy heartbeat of North Minneapolis, the Minneapolis Urban League. The building is called the Gary Sudduth Gleason Glover Center for Neighborhood and Economic Development. We're glad to be here, and we are announcing today that we'll be broadcasting from this location for the next several weeks. Therefore, we invite you, dear community, to join us, to be a part of our audience, part of our program. We've always said that this is about creating robust conversation. Our objective here is to create a place, a space where we can talk to each other and talk to the world, to share our point of view, our sense of dignity, our sense of curiosity, our sense of challenge, and to encourage our point of view to be part of the public dialogue. We always promise robust conversations, and today will be no exception. I want to begin by thanking our sponsor, the Pfizer Corporation, and our partners here locally who help make this broadcast possible. They include UCare Minnesota, North Point Health and Wellness Center, Open Cities Healthcare Center, and a special thanks to the host organization, the Minneapolis Urban League, and its interim president, David Ogwamanon. Well, today I want to begin by setting and introducing our special guest. We're using video conference technology and being joined by two speakers who are in far-away sites. Dr. Herb Smitherman is the Assistant Dean of Community and Urban Health and Assistant Professor of Internal Medicine and the Karmanos Cancer Institute at Wayne State University. He's also president and CEO of Health Centers Detroit Foundation, a federally qualified health care center look-alike in the city of Detroit. His research and expertise focus primarily on creating sustainable systems of care for urban communities, for which he has received more than $10 million in grant funding. Dr. Smitherman has spent the past 21 years working with diverse communities in Detroit to develop urban-based primary care delivery systems that integrate the health, social goals, and concerns of the community. He recently co-authored and released a book. The book is called Taking Care of the Uninsured, A Path to Reform. And we're joined in Washington, D.C. by Dr. Gary Puckrine. Gary A. Puckrine, PhD, is the President and Chief Executive Officer of the National Minority Quality Forum. Dr. Puckrine also serves as Executive Director of the Alliance of Minority Medical Associations. It's a collaborative effort of the Asian and Pacific Physicians Association, the Association of American Indian Physicians, and the National Medical Association. In 1998, he founded the forum's predecessor program. It was called the National Health Month Foundation, to help communities and policymakers eliminate the disproportionate burden of premature death and preventable illness in special populations through the use of evidence-based, data-driven initiatives. Well, they are joining us from outside the community. We're glad to have them as part of the program. Locally, our panelists include Stella Whitney West. Stella Whitney West has over two decades of experience working with governance and policy boards of nonprofit organizations and more than 15 years of senior management and experience in the Twin Cities nonprofit community. And she is the Chief Executive Officer of North Point Health and Wellness. Prior to that, she served as the Chief Operating Officer for North Point's Human Services Division. And Dori Gabolo, she's CEO at Open Cities Health Center in St. Paul. She directs operations at one of the largest nonprofit community health centers in the Twin Cities. OCHC sees over 16,000 patients each year. That translates into over 56,000 visits. Of these patients, 1/4 are uninsured. The Multicultural Clinic has a broad client base made up of African American, Southeast Asian, primarily Hmong, African immigrant, and Caucasian patients. The clinic provides medical, dental, and mental health care and sees everyone regardless of income or insurance. They've got a huge outreach and education department that provides classes, health screenings, and support groups. Last year, Dori Gabolo was named Healthcare Hero by Twin Cities Business Magazine and Care 11 News. And I think last night they were on the national news with Brian Williams, so Dory Gabolo. Well, this is a great panel and a great conversation, but let me begin. Our topic today is pay per performance. And I want to go first to Dr. Puckrein. And Dr. Puckrein, for the sake of our listening audience and for this conversation, if you would, what does it mean when we say pay per performance? What's happening in the strategy to provide competent health care for communities that is under the idea of improving through pay per performance?
There is a growing presumption in healthcare that we can find standard of practice. The idea is that for a range of diseases, there are best practices out there that as physicians would follow would improve patient outcome and reduce cost. It is trying to move method, which is still very much an art form, and the doctor speak for himself, but the presumption is that we can now move it into the realm of science by specifying what care is appropriate for what, and then physicians and providers are rewarded in terms of their reimbursement by following those guidelines. It's fraught with danger, but that's basically the art of what pay for performance presumes.
Fraught with danger, what do you mean? What are the problems? At its surface, it sounds like a good idea. It talks about, it seems like we're talking about accountability, responsibility, and it talks about if you produce results, you get paid. But what are the dangers with that strategy?
Well, I'll focus on African Americans by way of an example, but we could speak about women, we could speak about the elderly, children, Hispanics in the same manner. African Americans, when you, this is the heart of it, we still don't really have the best science. When you look at clinical trials, African Americans in this country have historically been underrepresented in clinical trials. The tradition has been to generalize from clinical trials that have been conducted in other populations as to what would be appropriate care for African Americans. The sense was that the physician determination of being consulting with his patients and his or her experience. What we see now is because there's this effort to move for pay for performance, some of that decision making being removed from physicians and from patients, and physicians are being rewarded to provide specific care. To give a concrete example, chronic heart failure. There are pay-for-performance guidelines for the treatment of chronic heart failure that ask physicians to provide essentially two different medications, ACEs and ARBs, in short. And what the science says is that that may not be the best care for African Americans. Yet the system, Medicare, Medicaid, and some commercial plans prescribe that by way of their pay-for-performance guidelines. Its implications for African Americans in terms of life and hospitalizations are really very, very serious, and that's but one example.